Hello, everyone, and welcome to Elemental Musculoskeletal Lecture. This is a med mechanics presentation, and this is intended for my students who are completing the module. It's also important that you know that if you haven't seen part one of this lecture, I will link it for you up in the corner here. Please definitely refer to part one if you haven't seen that one first. All right. So just a brief reminder that we talked about how there are multiple elements of the musculoskeletal system. And in part one, we went over bone and muscle disorders. And today in part two, we're going to go over connective tissue and nerve disorders, as well as trying to combine all of the elements together to show you what an injury of one particular area of the musculoskeletal looks like. For example, joints disease. So we're going to go through all of these today. Let's go ahead and get started. So the first thing that you have to understand about the connective tissues is that these tend to be the hidden supports, right? So if a muscle is injured, a bone is injured, or even sometimes certain nerves are injured, they take the credit. There's names for them. There's very common disease patterns for them. But we often forget about the connective tissues that are involved in our body's joints and movements, even though their only job is to do something as simple as support or allow no unintended motion, right? So your knee can't go to the side. We typically don't name a lot of these connective tissues, and they're typically easily forgotten about. So this is important for us to know about, because when somebody has an injury in a part of the body, usually a joint, sometimes this won't show up in x-rays. Most of the time it won't show up in x-rays. A lot of the time it won't show up even in CT scans. And so this is one of those injuries that we need to understand. Just because the patient has been complaining of pain for a while or nothing shows up on the scan doesn't mean that there isn't a problem underlying. These connective tissues are really important, and they heal very, very slowly. They can lead to quite a lot of pain or malfunction in whatever part of the body that they have been injured in. And so it's really important to know that vague injuries should always be referred to sports medicine or orthopedics. And you should always remember to tell the patient that this is not in their head. This could be some sort of connective tissue injury, and that some of these injuries, if they're true complete tears, can only be healed with surgery. Connective tissue diseases are usually only found when they're complete tear or rupture when they're on MRI. And that, again, that's not something that we're doing in the emergency department. So that is another piece of information you can let your patients know. Now, in order to do a connective tissue examination, you need to understand that there are lots of different kinds of tissues, and you need to kind of understand that what we're going to do is we're going to put a lot of stress and strain on whatever part of the body that we're going to be testing. So we're going to apply this to a knee here in the next slide. But what I want you to know is that doing the examinations there's not always an exact science to that. You can just understand the way that joints are put together, and you can sort of figure it out and extrapolate from there. Now, again, remember that on the right-hand side, we have a whole bunch of questions to help with your active learning over passive learning, and we don't always answer all of those questions here in the lecture, so you can always pause or write the questions down and see if you can answer them. They are almost all Googleable. So let's get to a very common connective tissue disease or injury, and that is the medial meniscus tear of the knee. Notice that this injury happens frequently enough that there is a named test for it. It's called the McMurray test. In the McMurray test, you internally rotate the knee and you sort of twist at the ankle, and that kind of grinds that medial meniscus between the bones of the knee. And if that is injured, obviously it will hurt. Now, this may seem like a really obvious test, and I'm sure these doctors felt very smart and brilliant in coming up with a lot of these tests. But just because you're dealing with a, let's say, ankle or a hip or an elbow, doesn't mean you can't complete the same kind of test, even though it's not a named test. So you can say, hey, I have some suspicion that there's a injury in this joint and I put a lot of pressure on it, or I twisted it in a way that it's not supposed to be twisted, like, for example, the ACL and PCL of the knee, there's similar ligaments in the elbow. Maybe you need to do some specific examination of each of the joints when patients complain of pain. Remember that these do not heal very quickly, and that if there is a true tear of the connective tissue or a true complete injury, we're not going to see it except on MRI, and this usually will require surgery to heal if it's complete tear. So they always need to be referred again to orthopedics or sports medicine. They may require some physical therapy. Giving them things like stretches and having them rest that joint is always really helpful. And here are some other examples of common connective tissue disorders. And the most common ones get names, right? You've probably heard of plantar fasciitis or tennis elbow, also known as lateral epicondylitis, right? Also, there's elbow bursitis, very well known. So it's important for you to know that just because these are the very common ones doesn't mean that they can't happen in other parts of the body. So we could have other tendinitises that happen in unnamed areas of the body because the patient is doing other repetitive movements besides just running. Bursitis can happen especially with an injury. So it can be a traumatic bursitis full of blood. It can be an infected bursitis, right, with a lot of cellulitis over top. Or it could even just be a regular old bursitis from repetitive movement in one area or another. The hip and elbow are probably the two most common sites of bursitis that we see. It's also really important to know that all of these areas are going to be swollen, they're going to be tender to the touch, and that there's not always a quick and easy, simple cure for a lot of these, right? So with plantar fasciitis, typically it takes a little while to heal. These people have to stop the repetitive movement, which runners never like hearing. And they have to do some physical therapy movements, such as rolling their foot on a ball and trying to break up scar tissue around that plantar fasciitis. Same is going to be true of the tennis elbow. They typically need to stop the repetitive motion, which again, they don't want to hear about. And they like having a strap or some kind of support tissue to help support that injured connective tissue because it can no longer do its job. Same with a bursitis. Typically, we do not put a needle in these bursitises because they almost always refill, and there's a really high chance of potentially infecting them if you do drain them. And even after you do drain them, they refill, like I said. So typically, we don't do a whole lot of drainage of these bursitises. All right, now let's talk in general about connective tissue disorders. Again, we don't deal with this a whole lot in the emergency department, so I'm not going to go into incredible detail on all the receptors and all the different kinds. But what you have to understand about the connective tissue disorders is that they're almost always genetic, and there's a bunch of them. It's not just a morphology issue. For example, it's not just a bone issue. It's not just a skin issue. There can be issues as to how the body is actually put together. For example, you can see this guy here that's pulling on the neck skin. This is a problem with the connective tissue of how the skin is put together. This is Ehlers-Danlos. There are lots of different types of Ehlers-Danlos, but just because the skin is put together in odd ways, it also means that the areas around the organs are put together in odd ways, and the joints are put together in odd ways. This makes them more vulnerable to certain injuries and disease processes. The same can be said of this gentleman down here with the scoliosis in the white shorts. He is long, tall, and gangly, and he has scoliosis. He most likely has a Marfan's type syndrome. And even though long, tall, gangly is more of a morphology, the way that his blood vessels are put together is also abnormal. And that's why Marfan's syndrome is very closely related to AAAs or ascending aortic aneurysms, because the blood vessels are made of the same kind of connective tissue as these particular bones are. And then, of course, the top one is a famous actress who has osteogenesis imperfecta, and you can see that her bones are shorter than they should be, again, because of a connective tissue disorder. Now, you just need to be aware of these in general, not necessarily all the intense depth that may be required in other specialties. But it's important to know that if you suspect a connective tissue disorder, and a lot of them go undiagnosed, you should remember their associations and that there could be problems on the inside as well. The other big connective tissue disorder that we have to talk about is compartment syndrome. And I know it sounds a little weird to use this as a connective tissue disorder, but the way that our body is put together with certain tight compartments, it's actually put together and in sections separated by fascia. And so it's really the fascia or the connective tissue that's holding the pressure in and causing the problem. So if there's too much pressure that overwhelms it, of course it can, the fascia is so strong that as the pressure increases, it completely compresses the blood vessels and the nerves. And of course, that leads to significant injury. We learn a lot about this. I'm sure you've already heard of it. This is a picture of a gentleman with a leg compression injury that has compartment syndrome. Typically, we learn the 5 Ps. But it's really important that you know that pulse is the last thing to go, and pain is the first presentation, especially pain out of proportion to exam. So if you suspect somebody has a compartment syndrome, you have to know the fasciotomy lines. Remember that you're not doing the whole body, you're only doing the area that is compressed or swollen. And it's also really important to know that time is of the essence. And so you don't call surgery unless you're at a big trauma 1 facility. Most of the time you are doing the fasciotomy. So it's important that you know where these lines exist. And it's important that you only do a like as bare minimum as you possibly can. It's important to call the physician if you have the chance and to try to measure pressures to make extra sure that this is actually a compartment syndrome. Remember that normal pressures are going to be 12 to 14. So you only consider a fasciotomy if a pressure is over 20. This is the exact same numbers for pressures as eye pressures. So it's not another number that you have to remember. Here's a lot more information on compartment syndrome. This is a little overwhelming to me, but some people like all the information that you need to know in one big slide. The most important part, I think, is down in the left-hand corner where it talks about the muscles and nerves and how much time you have. The important areas is with muscle, you have 8 hours where it becomes irreversible. And with nerves, you only have 6 hours. So it's important that you don't let these patients suffer that long whenever possible. But I'm going to let you review this on your own time if you're interested. We already sort of talked about how we have connective tissue and bone and muscle and nerve all equals joints together. And there's a lot of other combinations that we could be doing. But I wanted to go through our swollen joint differentials. Now remember that this isn't just a knee, even though that's all I've pictured here. So if you have a swollen joint, you want to consider things like trauma and overuse injuries, sprains and strains and hematomas. You also want to consider things like gout, if they're older patient, or pseudo gout, something like a septic joint. And remember that most patients with septic joints, they don't know how they got it. Not all of them have a previous injury to that area. Some septic joints, like if you're septic with gonorrhea, for example, you may not have symptoms in that joint area to begin with, or any injuries there. And then, of course, you need to consider hematomas with hemophiliacs or people who have really high INRs and spontaneous bleeding. And then, of course, you always need to consider bursitis. Bursitis versus an actual swollen joint are going to look a little bit different, and it's important that you make that distinction. I always like to talk to my students about the difference between joint swelling and bursitis swelling. Notice again that the bursitis is sort of small and contained, whereas the joint is very circumferential. It's all the way around that joint, even on the medial aspect, whereas the bursitis, you only have swelling on that very tip of the elbow. Both of these, if we aspirate either, are likely to refill. So the big question is, why should we aspirate these? And the answer is we shouldn't, especially with the bursitis. You should probably just put some compression on that and leave it alone. Sometimes they go away on their own, especially if they quit using that joint as frequently. The answer with the joint swelling is that we might need to get some fluid out of the joint to diagnostically diagnose septic joint. But if we're not suspicious of septic joint, we shouldn't be putting a needle in it. So here is a couple of examples of some septic joints. Notice that it almost looks exactly similar to gout or cellulitis. Physically on exam, you cannot tell the difference between septic joint, gout, or cellulitis. You cannot. I don't care which doctor tells you that they have the experience and they know, they don't. Which is why typically we need to put a needle into a joint to determine whether or not it's septic. However, you don't want to put a needle into a joint over cellulitis, so this gets kind of tricky and complicated. If you do aspirate, obviously gout is going to come out with crystals. So that one is probably the easiest one to figure out. If there's no white blood cells in the fluid, then it's probably more of a cellulitis. And if there's a whole bunch of white blood cells, typically over 50,000 white blood cells, then it's going to be more of a septic joint. Now you can see in the picture down below that the fluid that is taken out of this knee is kind of opaque. It kind of looks a little bit like pus. That is probably infected. Normal fluid inside of a joint looks yellow and clear. It's also important that you should consider that septic joints, when they've been sitting on that joint for a little while, can spread into the bone, because obviously that joint infection is just sitting there. And you also need to give some antibiotics for these. Septic joints are often thought about in older adults. And I really want to make sure that you know that septic joint is the most common cause of hip pain in infants, and that's kids under 8 months old. So don't necessarily think about this as an adult-only disease. And if you're not really sure whether or not this is something that you should follow in clinic or not, draw an ESR and a CRP. And this is something that you can kind of talk to your orthopedist about and decide whether or not you should be aspirating or not. Now, of course, we get to talk about gout versus pseudo gout. You can see in this picture here that there is a tophus formation. This is almost always occurring with gout. And you can see these little white spots of the buildup of all of the crystal. This table that I've included on this page is, I'm going to call it the textbook answers, right? Typically gout is smaller joints and pseudo gout is larger joints like knees. Whereas gout is like toes and fingers and wrists. And you can see that they're always painful and inflamed, and that there's a real big difference in the crystals that are sucked out of these two different diseases. Really sucking fluid out and looking at the crystals is really the only way to tell the difference. In practice, it's possible to see pseudo gout in a small joint, and it's possible to see gout in a large joint. It just depends. It's also important for you to know that some people just draw a serum uric acid count to look to see if this is gout. That is not good enough in the emergency department. It is very easy for somebody to have a high uric acid number and them to not have gout, or for them to have a low serum uric acid number and to still have gout. So we're not really sure that uric acid serum wise is useful in the emergency department. Here's a couple of options for acute treatment, specifically of gout. Remember that each of these can cause side effects, and they do have reasons why you should or should not use them, particularly colchicine, which definitely should not be used in pregnancy. Now we can talk a little bit about some autoimmune problems of joints. There are quite a few autoimmune issues, including things like rheumatoid arthritis, which is an autoimmune attacking your joints. But then, of course, there's also lupus, which is very commonly known for causing abnormal joint problems. There's even juvenile arthritis in pediatrics. Almost all autoimmune flare-ups are treated with steroids. And typically I tell people don't give steroids unless you know already that that's exactly what is going on here. A lot of these people already know that they have a diagnosis, and if they don't, they need to follow up with a rheumatologist. Now we can talk a little bit about some nerve problems, and it's really handy to know your dermatomes of the skin, as well as which nerves innervate which joints. And luckily, these answers are almost all easily Googleable. So if you don't know that these exist in Google, please know that they do. So probably the most common nerve disorder that we see in musculoskeletal problems is degenerative joint disease or radiculopathies. Usually this is kind of any nerve impingement, right? And it's going to cause that tingling, paresthesia. Sometimes it can even cause weakness. Most likely we're seeing this in the cervical spine, so we're seeing it in the arms, but you can also see it in the legs as well. That's what sciatica is, right? The important thing you should know is that opiates are the last option here. While a lot of people immediately go to opiates to help with radiculopathy pain, nerve pain is really only tempered by opiates, and we shouldn't start with that. Typically, something like NSAIDs and muscle relaxants are two combination medications that are really good. We also like using medications like gabapentin, which are also really good to use for this disorder. This is another nerve problem that's a little bit less common. It's called the lateral femoral cutaneous syndrome, also known as myalgia paresthetica. This happens in obese individuals, or maybe even in pregnancy, where this superficial nerve that comes up over the pelvis and it innervates just the skin on the side of your thigh gets compressed. Again, because of obesity or pregnancy, maybe even because they're sitting at a desk too long. And you just get this complete and total ice cold numbness on the lateral side of their thigh. This is obviously an issue where the nerve is being impinged. And typically you need to treat this by not sitting at desks very often, by losing weight or giving birth. And typically laying flat helps this pain. Again, there's not a great treatment for a lot of these nerve pains. Gabapentin can help, NSAIDs can help, so can icing and cooling, but there isn't a whole lot of things that help that pain. Another big nerve injury that we always talk about in the emergency department is cauda equina syndrome. Notice that this is the impingement of the last part of the spinal cord, or the cauda equina, right? And though the nerves that come out there are really important, they tend to be the ones that innervate your bladder and your rectum, so that way you can hold yourself and go to the bathroom or not, which is why we start by looking for bladder retention first. We also look for things like saddle anesthesia, which is anesthesia, like numbness in the area of your groin. And then we also will find bowel and bladder incontinence, which is a late symptom, right? So the first symptom is bladder retention, and then the late symptom is incontinence. We can also hear about erectile dysfunction or muscle spasms and weakness. I also think it's really important that you should know, I've seen quite a few of these cauda equina syndromes, and you can't just ask a patient, can you feel your genitals? Because everybody's going to look at you like you're crazy and say, of course I can feel my genitals. But if you actually go in and touch the crease of their leg and say, can you feel that? They can look panicked and say, no, actually I can't. I didn't realize it. Because this is not something that you typically think about, right? You don't typically test whether you can feel that area. So don't just ask your patient. You actually have to test it, as awkward as it is. This cauda equina syndrome is probably one of the only reasons to order an acute or an emergent MRI in the ER, because even though this usually takes 8 to 10 hours, this will result in emergent neurosurgery, either transfer or consultation. And a lot of times they'll take these folks to surgery immediately to relieve the pressure off these nerves. So if it's going to result in a big changing diagnosis differential, then you should go ahead and get that MRI or transfer somewhere where they can. It's also important to know that if somebody has recently had a LP, or if they've recently had spinal surgery, especially in the lumbar area, a hematoma can also cause this. It doesn't always have to be a disc bulge. It could also even be an infection, like an epidural abscess or cancer that pushes on this spinal area. So while a lot of people think about disc bulges, you can also ask about surgery and IV drug use and like prostate cancer, for example. So know that there are lots of other causes of cauda equina besides just the typical disc. Now let's have a little bit more combination thinking. Let's talk a little bit about back pain. So the first big cause of back pain that we see in the emergency department that's a bone problem is a vertebral compression fracture. This usually occurs in elderly, although it doesn't have to be. Some falls can cause it in young people, but it's almost always a fall or a trauma. And if you do find a compression fracture, obviously it hurts just as much as any other fracture, and it can cause lots of muscle spasming. So typically we like giving muscle relaxants, and we treat this with a special brace called the TLSO brace, or thoracic lumbar spine. I forgot what the O stands for, but it's an orthopedic or something like that. But it's a brace that pretty much looks like a corset that goes over your thoracic lumbar area and sort of gives a little bit of extra support to your vertebra to prevent the total and utter compression of this area. This is okay to go home with pain meds. Remember that I would always include some kind of muscle relaxant as well, because this area is going to cause quite a lot of inflammation and muscle spasming, being that your muscles are going to have to work a lot harder to hold up your spine. Another big bony cause is spinal osteomyelitis. Most people think about it in foots, specifically with diabetics, but remember that it can occur in your back and specifically your spine. So if you're worried about this and you're like, I don't really see anything, but maybe they're an IV drug user, or maybe they have an infection nearby, that's probably the most common cause, is an infection nearby. Get an ESR CRP and really always suspect it. You can usually see this on an MRI or a CT. And usually spinal osteomyelitis, just like other osteomyelitis, requires antibiotics for 4 to 6 weeks. So while it's good to admit them initially, if they've had it for a little while, know that you can encounter patients with known spinal osteomyelitis that are still on antibiotics. This is definitely something that's very slow healing, and this can, of course, lead to cauda equina syndrome. So if you hear somebody who's on antibiotics for spinal osteo, and yet suddenly they're having problems controlling their bowel or bladder, definitely always consider cauda equina. Another back problem issue is the epidural abscess or hematoma, right? We kind of already went over this when we talked about that, but you always want to consider, like, do they walk okay? Is there weakness of the legs? Are they having muscle spasms? Remember that when you look at the back, you may not always see any cellulitis or obvious causes. So you really want to listen to what the patient's saying and decide whether they're high risk or not. Another cause of back pain that is often missed, and again, very rare, is something called a psoas abscess. So the psoas is that big muscle here that crosses the pelvis, and psoas abscesses happen spontaneously. You can be at high risk for them, for example, an IV drug user, but any surgery can lead to a psoas abscess. And sometimes we have people who just get them spontaneously who are otherwise healthy. This is something that will usually be identified in a CT, and it can mimic things like back pain, kidney stones, appendicitis, or even radiculopathy. Remember that just like any other abscess, it requires IND, which means that they probably need surgery to relieve the problem. Another cause of back pain that we should be aware of is our AAAs or our dissections. Remember that CT scans or ultrasound can reveal these pretty easily. For AAA, anything over 5 centimeters means call surgery. That's where we have determined that the vasculature can no longer stretch and is more likely to rupture. Remember that a lot of people can have known AAAs at 3 or 4 and just be watching them, right? Blood control is also really important because we don't want to exacerbate that stretching and cause rupture. A dissection, however, is something that can be chronic, but is always something that a surgeon needs to be involved with. You can see the picture of the ultrasound here, where you can see that there is a false lumen and a real lumen, and then there's clot in that aorta as well. Here are the leading causes of low back pain, specifically lumbar. This is a mnemonic that I did not come up with, but was often tested on. So fracture for spinal fracture, AAA, cauda equina, some kind of tumor, right? Like prostate, maybe Mets that we didn't know the person had. O stands for other, which could be osteoarthritis, right? Or disc problems, muscle strain, that kind of thing, infection, and then disc herniation. Here are red flag symptoms in back pain. I use this pretty frequently to help pad my chart to help discharge a patient. So I usually will say tuna fish negative in the same way that I will say heart score negative. So tuna fish has been studied quite frequently. If you're really interested, please definitely Google it. But this is something where if a patient has not a single one of these red flag symptoms, then they don't require any imaging and they are okay to send home. Now let's talk a little bit about hand pain. Again, this is another big combination musculoskeletal disorder that you're going to see quite frequently. Here's a little bit of the nerve distribution on a hand. Believe it or not, this comes in handy a lot, especially if you're worried about impingement at the neck, or if you're worried about any kind of like swelling or infection any other place on the arm. Here is example of the vasculature and where the nerve distribution is. Notice that there's a little tiny nerve that goes straight into that muscle on the thumb. That is a nerve that you should know. We're going to talk about that here shortly. That nerve in particular does this movement called the opponens, and that's touching your pinky to your thumb. So if you're worried about hand injuries and you want to document that the hand is still functional, it's important that you have the thumb touch every single finger. And if the thumb can touch the pinky, then that's called the opponens. And that says that that little tiny muscle from the median, or little tiny nerve from the median nerve is able to be functional. So let's talk about flexor tenosynovitis. This is rare, but is an extremely important emergency. And there are 4 signs called the CONNECTIVE signs that you need to document and you need to talk about with your orthopedist if somebody has this. So it's important that you know that this is a flexor tendon problem, right? So it's actually a problem of the tendon sheath, and it's an inflammation and swelling of the flexor tendon sheath. This is almost always caused by some kind of trauma or some kind of infection. And you can see that what you're getting is with even passive extension, it hurts. It's held in flexion because of the swelling of the sheath. And if you touch it, it hurts. And the finger itself is sausage-like swelling. So that means it's circumferential swelling of the entire finger. This is something that you need to be aware of. You need to know all 4 of these signs and you need to document this. Again, it's going to be really rare, but when you do see it, you need to call the orthopedist immediately. Another problem with the connective tissue disorder is de Quervain's tenosynovitis. So again, this is the tendon sheath, tenosynovitis, right? That's the problem. And it's actually over the thumb. So you can see that I've put a blue arrow here on where that sheath exists. And you need to have them make a fist and tuck their thumb into the fist and then go have them push their wrist down. If you have them push their wrist down, as you're seeing in the picture with the blue arrow, and that gives pain, or you tap on that area pointed to by the blue arrow and it's pain, that's usually de Quervain's tenosynovitis. Sometimes this has swelling that's obvious with the eyes, but a lot of times it does not. And this can lead to thumb malfunctions as well as paralysis. So this is something that you don't want to miss. You also, typically these people are treated by giving them the same kind of treatment as carpal tunnel, which means that they have to wear the little wrist splint and they have to rest their wrist. Sometimes they have to go in and cut open this fascia or tendon sheath, and that's going to cure their problem. Next big thing we have to talk about is thumb or flexor tendon injuries. So if you have an extensor tendon injury, as demonstrated here on the right side, extensor tendons are not big deals. Typically, even us in the ER, we can sew them back together. Usually it's just one thread. And this is because in the hand specifically, extensor tendons are not as important as the flexor ones. So if we have a flexor tendon injury, whether it be from trauma or laceration, or if you just happen to find one, as shown in the picture down below, you need to call in the hand surgeon. And this is the flexor tendon injuries usually end up going to the OR because these muscles are so much stronger than the extensors. This can cause permanent function problems. So please call the hand surgeon or ortho if you see or happen to notice a flexor tendon injury. Remember that you can't always see it as clearly as in this picture, which means that you need to be doing testing with all of your lacerations to the hand specifically. You need to care a lot about the flexor tendons in specific. Oops, looks like I skipped one. Sorry about that. This is a tuft fracture or a tip degloving. We see these quite commonly in the emergency department and probably in urgent care as well. So what you can see about both of these injuries is that they are clearly a fracture. Even though they're open to the air, these are not typically treated like open fractures. No antibiotics are needed. This is new. Okay, old school orthopedists will still ask you to give antibiotics, but it's important you know that almost all of the literature now completely supports that these little tiny tuft fractures or these really obvious like injuries to the tip of the finger do not need antibiotics. These are not treated like open fractures anymore. Typically, these can be either sewn like normal, or you can just wrap up the finger. This does not need to be transferred to an orthopedist, that you don't have to call them to have them come in. The only time you need to call them is if the bone is sticking out of the finger and they're asking you to shave it off. Typically, that's not something done by us in the ER. But if you can just wrap it up or you can just sew it up, do so. Now we're going to talk a little bit about nail bed injuries. I know that a lot of the nurse practitioners that I work with initially were really, really worried about handling a nail bed injury. And it's important that you know that it's very easy to suture these. It is very outdated information to take a fingernail off. So do not, I repeat, do not rip off a fingernail. It's not because we want to save the fingernail. It's because that nail is actually protecting the bed beneath it. So obviously you don't have to rush around and try to sew the fingernail back on, but it is really handy. And I will put fingernails back in and sew them back in to protect that nail bed from both injury as well as infection. So you can see several pictures here that show that you can sew the nail back to the skin of the finger. This is a very easy. The nails or the needles that we are given very easily go through fingernails. Do not hesitate if you need to do so. We don't care about nail cosmetics. You can see the picture in the bottom that these nails actually come back together pretty nicely most of the time, especially the younger the patient is. So protect the cut. Don't worry about sewing the fingernail to the injury, and don't be afraid of them, I guess. Don't pull off the fingernail just because it looks pretty. Don't do that. That's very old school. And if you have any questions, let me know. And that ends our musculoskeletal discussion. If there are any questions, please definitely submit them in the comments below, and I will see you guys next time.